Hello, we are Group 7 consulting firm. We are here today to present our plan and findings while implementing a program of change at this Midwestern hospital. Our firm worked closely over the past several months with the hospital leaders and staff to develop this plan and implement it and assess outcomes along the way. When we were first hired onto this project, the hospital's emergency department had a couple of problems identified. First, there was a lack of cultural competence among staff working in the ED that was occurring secondary to an influx of immigrant and refugee patients from Somalia and Syria. The second problem identified was an increase in ED visits for non-emergency healthcare, such as the common cold. A bit of background on these problems. The patient population has changed over the years. There's a more diverse resident population that now lives surrounding the hospital. Staff, however, has not been provided education regarding cultural competence and training to better care for immigrant and refugee patients. Increased wait times and non-emergency visits due to lack of primary care visits for lack of knowledge that things can be treated at a primary care office, or limited healthcare access also contributed to these problems. When we came onto this project, we found long wait times in the ED, poor patient satisfaction scores, as well as poor efficiency related to the crowded emergency department for non-emergency healthcare visits. There's also a lack of effective communication between staff and patients from different backgrounds. Our recommendation was to establish 3 measurable and realistic goals to achieve improved patient satisfaction scores, as well as decrease the non-emergency visits to the ED and better the access to primary health care in the surrounding area.
For our plan development, we chose the Cotter-Harvard Business Review Model. We chose this model because it involves all team members from various angles of healthcare in order to establish a more cohesive goal and plan. The model focuses on short-term goals and improvements while working towards the main goals. Our 3 main goals were broken down individually, following the 8 steps in order to identify a problem behind each goal, develop a plan to address it, and implement change and monitor outcomes. The 8 steps to transform are: establish a sense of urgency, form guiding coalition, create a vision, communicate the vision, empower others, plan for and create short-term wins, consolidate improvements and create more change, and institutionalize the new approach.
The Harvard Business Review Model has 8 steps to transformation. The first step is urgency. This is pretty much identifying needs and opportunities. So our biggest need was for this primary clinic because the rates of ED visits were so high and uncontrollable, and a lot of the staff lacked cultural competencies. Forming the coalition is next. So this is forming a team. Our team is composed of several members, as mentioned above, our Grey's Anatomy's teams, if you noticed, to create a better healthcare system for the influx of this minority population. Next, we want to create a vision. So our vision was the goals that were mentioned above. We also want to empower others. So we're trying to get rid of obstacles and change the system a little bit. So we want both the staff and patients to be well educated, and this can be evidenced by the lower ED visits and less chronic condition exacerbations. We also want some short-term wins. So through a variety of methods, the patient and staff, they're all satisfied. We also have less ED visits, more clinical visits, and the staff itself is more culturally competent. We're recognizing wins here. We also want to have some improvements. No one's perfect. Several improvements are needed and were made to enhance the quality of care and needs for the primary clinic and the patients themselves. Here, we're developing and implementing change while reinvigorating the process with new ideas. And finally, we have a new approach. Changes will be made to adapt to the diverse community of the clinic and its surroundings. So here, we're going to be increasing performance and productivity while creating connections and a better performance rate.
For our 3 goals, we tried to focus on the 2 main problems the emergency department was experiencing. one of which was a lack of cultural competence by the employees and the emergency department being used for non-emergent conditions. Our first goal was to increase patient understanding of their chronic illnesses. We believe that this would lead to a reduction in emergency department visits because patients were truly able to identify what was emergent and what was simply a part of the disease process of their condition. Um, our other goal was to help patients manage their conditions by creating a primary care center to teach newly diagnosed patients about disease management, as well as providing primary care services to help address the lack of primary care providers for this community and to increase overall positive health behaviors. Another goal we set was to increase cultural competence among our staff because it seemed that our staff had grown accustomed to a certain kind of patient and seemed unwilling to provide appropriate care for our current patient population. We wanted our staff to be able to provide a high quality of care to all patients, not just a certain kind of people.
The first outcome we achieved was the overall reduction in visits to the emergency department. One of the major issues we had been facing before project implementation was ED overcrowding, which was drastically overworking staff and rapidly depleting resources. Through the numerous changes we implemented within the organization, we were able to decrease the number of patients coming through the ED to a steady, much more manageable level and ensure appropriate use of emergency services by the community. Success related to this outcome are exemplified by a 30% decrease in ED visits due to non-emergent cases such as viral infections, a 20% reduction in ED costs overall, and a 45% increase in staff satisfaction among those employed by the Emergency Services Department. Following Cotter's 8-step change model, initial sense of urgency regarding the less than ideal ED environment was disseminated throughout the organization by key change leaders, including Owen Hunt, EMS nursing manager, and Joe Wilson, lead EMS nurse practitioner. Multiple sources of information, including meetings with patient groups and ED staff, helped the leaders to gather information that served as evidence necessitating change. A coalition committed to the issue at hand was formed, including those listed on this slide, and it was agreed upon that the best solution was to create educational programs aimed at both patients and staff, with the end goal being the reduction of emergency department visits. Multilingual handouts, one-on-one interactions, and group meetings are just some of the many strategies used to enact this project. Ongoing education and maintaining open lines of communication between all stakeholders of the project helped to keep progress and change going. The second outcome achieved was increased cultural competence among ED staff. Cultural competence played a major role in the appropriate care, education, and overall communication with patients from minority groups, ultimately influencing how later parts of the project plan, namely patient education, went. Success related to increased cultural competence can be seen through a 75% increase in patient satisfaction related to perceptions of culturally appropriate care received, and a 45% increase in cultural competency scores among staff. Again, implementing Cotter's change model, the initial sense of urgency related to a culturally insensitive ED was disseminated by change leaders, namely April Kepner, patient representative, along with other members of the guiding coalition. Institutional barriers such as money, time, and overwhelming accumulation of responsibilities were mitigated by the coalition through secured funding and hiring of additional staff to make responsibilities related to change less of a burden. Simulated training environments and virtual educational modules served as primary sources for dissemination and teaching of culturally appropriate practices to ED staff. In order to uphold Kaizen, or the idea of continual improvement, constant feedback from patients aided in appropriate adjustment to cultural competencies taught to healthcare providers. It quickly became clear that many people in the community, a large proportion of them immigrants, used the emergency department for all of their health needs, as they did not have any other source of health care. This need led to our third outcome, the development of an APRN-led primary healthcare clinic. This clinic gave patients a resource for health maintenance and overall well-being that they previously lacked. In only 24 months after the initial concept was presented to the board, the primary care clinic first opened its door to patients. In the first 6 months since the clinic's opening, there was a 57% increase in patient visitation to the clinic and a 50% reduction in the number of non-emergent visits to the ED by these patients. Patients seemed to utilize the emergency department so often because they did not have anywhere else to go in terms of healthcare. To spark the need for change in regards to this issue, financial and logistical data that justified the creation of a primary healthcare clinic were circulated throughout the organization to build morale for this large undertaking. Once funding was secured and socioeconomic barriers, such as transportation to and from the proposed clinic, were addressed by team members, the clinic was created and offered to the public. Through the use of advertisement, patients were encouraged to use the clinic when needed, and, as we can see, has been a great success since its implementation. The final outcome the team met was increased patient knowledge related to disease management. The ED had seemingly been bombarded by patients of minority populations, putting strain on both staff and resources, and creating frustration within the emergency department that most likely led to the presence of insensitive care. These patients, however, simply lacked knowledge related to their disease processes and the operation of the U.S. healthcare system. All they knew was that the emergency department was for healthcare, so that's where they went. With proper education related to disease management, however, the amount of chronic disease exacerbations necessitating ED visits decreased by 50%, and there was a 30% increase in patient satisfaction related to these educational workshops that had been developed. By simply intervening in the cycle of disease, the team was able to improve the overall health of these patients. Educational workshops, as well as one-on-one provider-to-patient education, helped to increase understanding of disease among these patients and aided them in taking control of their health to achieve better outcomes. Team members, namely Amelia Shepard of Social Services and April Kepner, patient representative, frequently surveyed patients on their current needs. This subjective information, along with statistical analyses performed by Owen Hunt and Joe Wilson, support the success of these programs for improving the health of this vulnerable population.
Advocacy is an integral piece in our plan of change as we aim to improve the patient and family experience and increase access to care here at Seattle Grace. To start, community leaders have and will continue to be involved throughout the planning and implementation of this project to voice the needs of the community. Affordable transportation to and from appointments will be offered to all patients at the new health center to mitigate associated barriers. Also, mental health care professionals, social workers, case coordinators, and interpreters will be easily accessible at the health center to provide mental health services and assist patients in navigating the often complex and intimidating health system. Our Diversity and Inclusion Director aims to cultivate a welcoming and respectful environment for all staff and members of the community, with core values celebrating equity, access, collaboration, reflection, and empathy. To improve cultural humility and competence of staff, trainings and involvement in outreach programs and service learning programs are required. This will help to develop an intellectual understanding of social problems, sensitivity for concerns, and a commitment to address them. After completion of these trainings, staff showed a heightened sense of self-awareness and increased understanding of their own culture, and were then able to compare their own experiences to those of the immigrants and refugees, and come to a better appreciation of immigrant and refugees for their strength they possess as well as the struggles they encounter. The new health center was designed in collaboration with an architect firm that specializes in ADA accessibility so that all individuals have equal access to the building. Lastly, Seattle Grace has a health system lobbyist that communicates with the government officials to advocate for specific policies that are important to and impact the members of the community we serve. To better engage the community, we have created an Instagram and Twitter account to actively participate in conversations. Promotional materials for town halls and community health fairs, along with multilingual educational information, will be published on all social media platforms. We have also created an app for our health center that is integrated with the electronic health record so patients are able to view lab results, communicate directly with providers, schedule appointments, and check wait times.
Moving forward, the clinic will be able to attend to the needs of all the patients regardless of their background. Although currently the clinic is focused on Somalian and Syrian populations, it will increase its knowledge of several cultures as well. The clinic will increase diversity while maintaining cultural competence. So let's look at some changes and next steps on the next couple slides. Gain insight from staff members early on regarding ED visits and the type of patients that they see. Speak with them regarding plan of care, time, and supplies needed to tackle situations and to prevent material and provider lost time. Hosting events and support groups for better staff and patient satisfaction for everyone really helps to express needs and concerns while having an in-person translator present to help promote more cultural competence. We need to listen, understand, and implement easy-to-use solutions to promote better care. Education is key here. Emails, flyers, handouts, community health fairs that are language friendly can have for honest, open communication. We can host lunch and meet and greets with staff and patients all together. Next, we can host meetings and gatherings like an open house to welcome patients with the local community to become more inclusive of the community's values, beliefs, and behaviors to meet their cultural and linguistic needs. We need to gather what we call real data, race, ethnicity, and language preference, well, before opening the clinic to identify all the disparities within the minorities. While we develop a more comprehensive computer-based training, we can add in a real patient simulation center or simulation centers in general, in conjunction with hospitals, the staff, and the community to expand our cultural knowledge. We're going to continue our pre and post competency training while completing annual mandatory educations and possibly receiving CEs for those based on patient and available timing for the APRNs, which could include telehealth like FaceTiming or mobile connections. We want to also increase the educational material pertaining to the most common needs of the patient, meaning chronic, non emergent, and possibly some emergent cases due to patients who come to the clinic first. We still want to make these easy to follow and clearly label. We're also going to increase our timings for the clinic by providing a more open timings for especially people that work. We're going to try to do a phone hotline slash triage for patients who lack insurance, childcare, and transportation in order to get to the clinic as soon as possible. We're going to achieve 100% patient satisfaction within 1 year of opening the clinic with help from our in-person training and diversity computer modules to make our staff more culturally competent. It is mandatory for all our staff. Our handouts and flyers are going to be printed in multiple languages and fonts, specifically easy to follow and clear wording. We're going to also have in-person translators who are present with patients as long as they need while they're in the clinic. We also have patient surveys that are going to be created and specifically outlined to provide better communication for our staff to change and mold to patient needs. We also want to decrease ED visits in the next 2 years by 75%. We're going to create an ED strategy tool, so it's like a flow sheet that shows symptoms that are emergent needs or if it's non-emergent. This can also be implied with our triage phone calling slash telehealth. We're also going to have a more specific one-on-one conversation with our patients, meaning we're going to have ample time to work with all our patients and address all their needs to prevent exacerbation and readmissions, because we're going to educate our patients via handouts, videos, demonstration, and teach back method as well. We're also going to provide health records for condition specific guidance.